class do you teach after this?
This is 442. This is computational cardiovascular.
Oh, it looks really interesting.
Yeah.
Hey, you.
Yeah, I know you disappeared. You fell off the map or something.
How are you? This your last year?
Yeah, my last full semester.
Well, probably not. You're probably like glad to graduate.
Yeah, glad to graduate and hopefully get a job after. But that's easier said than done. But how are you holding?
I'm doing all right.
Yeah.
I made his 401 class, and then I just stayed here for like the extra hour after.
Oh, I'm jealous.
Why? Because it's easy.
No, because he's a good professor.
Thank you.
It's like I'm blushing.
Well, I just it's kind of hard for me to understand that stuff.
Yeah.
Like to know like which one of those equations to use. Although Excel makes it a lot easier, like in terms of like it makes it easy to crunch the numbers, but
You still need to know which one you're using.
yeah, how do you set it up at the end? Yeah, like I'll end PMT, what's that? Easy.
Yeah.
Start off there, but then kind of like. I wasn't expecting it to be that, but. So, I don't know. But I have to pass it on and punch yeah, the only reason why I said over 8 minutes is trying yeah.
Oh, that makes sense. That sucks. Well, enjoy your class. It looks interesting. Yeah.
That's a question real quick. Sure, one more question. Well, more of, I feel like I might doing prompts. Is it just as straight as board as that?
Yeah. First one's pretty
we
easy.
We didn't have to like rederive that equation.
No,
right?
no.
Just took the general form and then apply our variables to it.
Exactly. Yeah.
And then we said some, it doesn't show here because it's not MATLAB, but the OD 45, the function only can take 2 inputs.
2 arguments.
2 arguments. Yeah. So would you just have to make them as like matrices?
Yeah. Which one's
like so if you had 4 ODEs,
yeah,
would you just put like 2 ODEs equals this one variable? And then you use
let me so you're talking
so about, like for number 3 it was
you're talking about the file with the ODEs themselves, or the one that runs ODE 45?
When you call the ODE 45,
yeah,
you can take 2 arguments. Just like how do you put like 3 different ODEs into 2 arguments?
Gotcha. Let me show you. Oops. So you're talking about this function right here when you're calling ODE 45. So
this has the TY, so it's like
yeah. So this Y actually becomes a vector, or a matrix, I guess.
Okay.
So this kind of expands into
because one is time, huh?
Exactly.
Oh, so you just expand the Y into
exactly
as many ODEs as you need.
Exactly. Actually, I was just talking to someone before this. So to make 3 variables, you would actually make this one a bit bigger. And so instead of just 0, 0, you do 0, 0.
Yeah, 0. Yeah. Make it a third.
Exactly.
Yeah.
Okay.
Okay, that makes sense.
May I borrow your key? I
Oh,
left my
sorry,
stuff
guys.
at key 304.
Oh, yes.
Okay, did you just make the line there?
That's 442. Because
Cardiovascular.
the way it's set up, it's not locked. But it's your Y doesn't match the conditions.
Yeah, because T is the one minute.
T is the line, yeah.
The other one.
So the way he formatted it, he said the commas that set it up.
Oh, yeah.
Well, let me lost it. Fuck it.
He's like, yeah.
Just, this one corresponds to these two.
Yeah.
That's why I got confused. I'll be the professor for the day.
Yes.
You want to teach it? I'll take a day off.
Alright, you can sit in my seat.
Yeah.
My guy, I don't know what I'm
DJ
talking
wants to
about.
teach it.
DJ wants to do it.
Well, you see this here.
DJ's like, I actually don't know what I'm talking about.
Yeah,
For
so-
problem 2, I think it was part C, the last one.
Yeah.
On the solution part, it had like P1, P2, and P3.
Yeah.
Like on the actual circuit, like those like weren't labeled. So is that something we have to like find from like your
Exactly.
circuit?
Yeah. So I took it off on the third one just because I want you guys to practice kind of identifying where those pressures are. And
So it'd be at each node, right?
It would be at the nodes.
well, it'd be on the capacitors. And so that's the pressures on the capacitors. And then you can trace them back to the nodes because everything that's connected by a wire is the same pressure.
It's prior to the capacitor, right?
Exactly. Yeah.
Oh, okay.
Yeah. So you start there and then you trace it back as far as you can. But as soon as you hit a resistor, then across the resistor, the pressure is going to be different. Yeah.
Okay.
Does voltage, like, voltage only drops through the resistor, not
Exactly.
through the inductor or the.
Well, technically it drops through the inductor too, because the inductor has impedance. So like whenever you cross a circuit element, the pressure is not going to be the same.
Capacitors have R equals 0, right? That's theoretically.
Pretty much, yeah. But the way we use capacitors in LPM, we always connect it to ground. And so we don't really talk about pressure drop over the capacitors because it's connected to ground.
It's something minus 0.
Exactly. Yeah. Mm-hmm.
You were saying start from.
Yeah.
Yeah. Yes, that makes sense. Oh. No, I don't. All right. Get it. Gotta be something. Just one thing? What? I didn't know that. Mr. Kids.
What you guess?
What you guess?
Yeah, today.
I got an A, but here. But it was also because.
Maybe we did 80.
Yeah.
Good.
No, it's because, I got the question. 80% to 100%. And I got like an 80%.
That was okay, some of it.
87 is it's like. Equation.
You grabbed it in school.
You didn't?
I did 89.
Did you get 60?
Dude, right?
Oh, and I have moderating too. Yeah,
I was gonna ask you for like problem 3, do you just want the code or do you want us to read?
No, just the code.
The code.
Yeah.
And then problem 4, would you want the code too, or just the values we got?
And the code too. Yeah.
Dude, I did. Well, I mean,
yes. Sorry, you guys are doing well. Man, you guys.
All right, it's 4 o'clock. Let's go and get started. All right, good afternoon, everyone. How's everyone doing today? Good. You guys good over there? Okay, so today start a new week, and so this week we are going to be today we're going to be going over the last of our lecture slides today on cardiovascular diseases and medical devices. So just another kind of lecture slide kind of day, and then Thursday we're going to be starting up a new unit on 1D model, and so we're going to go over what that means, the equations for that. It is a pretty math heavy topic on starting on Thursday, so a little bit of an extreme week. We're going from nice pictures and Dr. Tran just talking straight for 75 minutes to equations on Thursday. So a little bit of a lightning and thunder, I guess you can say. Okay, so over the weekend, you guys gave me your preferences for your final project. So thank you everyone who answered that poll. So you guys should have gotten, everyone in the class should have gotten an email from me regarding their image data. So did everyone get their email from me with the Dropbox link stuff? Okay, good. Yeah, so your image data is there. What you should also notice that inside that Dropbox folder, there is at least, for some of you, I was able to get some actual pictures of what the model looks like. But for most people, there's at least a PDF document inside that folder as well. So that PDF document has, it should have a picture of what your finished model should look like, as well as some information about the patient itself. And so some of you have healthy patients, some of you have patients with disease. So if you hadn't had a chance to open up that document yet, I would definitely take a look, just because a lot of those diseases, we're talking about in this lecture today. And you're going to be referencing those diseases and doing further research on them for the final project. Not for the midterm project. Midterm project, you're just constructing the geometry. But for the final project, when you do the simulations and the report, I want you guys to, really dive into that. I think actually a few of your images are actually from animals too. So I think so there's been a lot of image data added to the repository since then. So I did grab quite a few new ones. So saw a couple of rabbits in there, a couple of lambs, and so some of you guys have some really interesting data. So should be good. All right. Yeah. So remember the final your final model for the midterm project is due about a month from today. So I think it's due middle of April. So definitely you want to get started on it. And especially one thing you guys will notice, and so I think for the most part, I haven't graded them yet, but I did take a quick look through your guys' kind of SimVascular tutorials. It seems like everyone was able to kind of figure out SimVascular pretty well. What you'll notice for your midterm project is that it's going to be a lot more difficult because the image data is not as clean, and so the tutorial is the tutorial for a reason. So that's probably the cleanest image data set I think I've ever seen. So definitely you want to start early. Definitely you want to get your questions answered, because I think the hardest thing you'll find with your midterm projects is just finding where to start. But once you have that, I think it becomes a bit easier. But, yeah. All right. Any questions I can answer before we get started for today? Okay. All right. So let's go ahead and pick up where we left off. So I think last time we were here, we were talking about aneurysms. Okay. Okay. So let's kind of go from the beginning here. So, last time we were here, we talked primarily about kind of two very common cardiovascular diseases. So we talked about high blood pressure. We talked about the dangers of that, kind of the incidence of that, and what that looks like from a biomechanical point of view. Okay. Then we looked at atherosclerosis. So atherosclerosis is, the scientific word for plaque disease. And so whenever you have kind of high cholesterol, fatty buildups in your vessels that kind of plug your arteries, that's basic atherosclerosis. So we spent quite a bit of time talking about this, what that looks like, biomechanically, what that looks like from a fluid mechanics perspective, what that does to the velocity fields and stagnations and where they occur, things like that. Okay. And then we ended the lecture on Thursday talking about aneurysms. So aneurysms is kind of this third type of disease that, surprisingly, we know very, very little about. It's still a relatively unknown quantity, despite, decades and decades and decades of knowing that they exist. But just with how difficult it is to get data and how difficult it is to even find patients that have these, there's still a lot that we need to learn. But just in summary, an aneurysm is kind of this abnormal growth or abnormal swelling of your blood vessels. And so it kind of creates this kind of like a sac that looks like in your, in your blood vessels, right? And there are a few areas of your body where the aneurysms are kind of most well known to grow in. So the first being in your brain. So these are called cerebral aneurysms, okay? So these are, little blood sacs that form in your brain. Very common, actually. It's about every 1 in 20 people have these in their brain. So remember, like I said, there's like all likelihood, at least 1 or 2 people in this room right now has one. And if they rupture, that's really bad, right? The funny thing is that, even though we know that that aneurysm rupture is kind of a big deal and it's a big risk for these people, we know very little about how they actually rupture and kind of the mechanics of how that happens. So some people think high wall shear stress causes rupture, and so it causes kind of like literal mechanical stress and shear on the blood vessel walls that cause them to break apart. There's a lot of compelling evidence that kind of supports that. And also, there's a lot of people that believe low wall shear stress causes the aneurysm to rupture as well. Something that has to do with the blood cells weakening just because they're not stimulated, and they kind of just maladapt and they kind of weaken themselves to the point where it ruptures. And so there's a lot of compelling evidence on that as well. And so I would say that when you have 2 groups of people that believe strongly in one thing and they're very opposing to each other, I think that means that we don't really know what's going on yet. So. Yeah, I was talking to someone after the class that said, maybe sometimes it's better to not know if you have an aneurysm at all, because if you have one, then you kind of always live under the stress of like, is this going to rupture? Should I treat it? And that by itself kind of degrades your quality of life. And so yeah, it's a tricky thing. All right, so we talked about treatments last time. So we talked about using a coil or using a clip to isolate it. And so both of these are very risky procedures, but they have been shown to work. So they are effective whenever they are implemented. Okay. So if you do have a cerebral aneurysm and it's deemed high enough risk, this is typically what a doctor will do to fix it. Okay. So enough about cerebral aneurysms. Let's talk about aneurysms in other parts of the body. So the other most common place for an aneurysm to occur is in your abdominal, actually. So actually, if you think back to this vascular tutorial that we all did, this vascular tutorial was basically your aorta that descends from your chest cavity down to your legs, and so we call that the abdominal aorta, right? So that's another common place for these aneurysms to form. So we call them abdominal aortic aneurysm, or AAA. Okay, not the car insurance company, the bad guy that can kill you. Okay. These aneurysms actually are very grotesque looking, as you can see here, and they're kind of some of the biggest swellings that you can see in the body. Typically, these aneurysms are fusiform in their variety, so they are kind of a local swelling. So they don't form a sac on the outside, right? So they kind of just locally swell, and it almost looks like someone that's kind of is kind of overweight. Although this has nothing to do with obesity or being overweight or anything like that. It kind of looks like it just from this image here, but this person, they may be a perfectly healthy, in shape person, but their aorta just tends to swell. Just like their cerebral counterparts, these are mostly asymptomatic, and so you'll never know that you have this until you actually do a medical scan for you, or you'll know that's there if it ruptures and leads to very significant pain and a lot of times death too. So that's kind of what's scary about these. And once again, even if these are detected, treating an aneurysm is a very, very risky procedure. And so a lot of times, doctors will look at one and just kind of leave it alone. And so that's kind of the risk that you run. Okay. I think some of your projects, and so a lot of people chose the aorta geometry or the aorta femoral. I think quite a few of you have an aneurysm in your model. So I think maybe like 5 or 6 of you have an aneurysm. So definitely something interesting to look at. What's unique about the abdominal aortic aneurysm is that it may form something called an intraluminal thrombus, or ILT, which is this kind of like very kind of fibrous, almost kind of like spider webby type of material that forms in the aneurysm that can really start to really gunk up your blood and cause, blood clotting and all kinds of bad stuff. One especially bad thing is that, this thing is very resource hungry. And so even though it's made of living cells in the body, but it doesn't actually do anything useful for your body. And so it robs the body of a lot of oxygen and robs the body of a lot of nutrients and makes that part of the body very weak to rupture and very just bad overall. All right, so here's some gross pictures. So usually I don't like gross pictures because I actually have a very weak stomach. But you know, these are some pictures of some intraluminal thrombus. And so it almost kind of looks like plaque a little bit. So you can see kind of it has this kind of like shiny sheen a little bit. But it's kind of like, you know, almost like tissue that it's like extra tissue that kind of forms in the body. It's kind of made of blood and a lot of other tissues in your body, but it's nothing more than just I don't want to say it's not actually cancer, but it kind of does kind of the same thing. Where it kind of just robs the body of a lot of resources. So yeah, gross picture. That's not a carne asada. That's something else. Okay. So the initiation and growth and rupture. So just like all aneurysms. So this is kind of just repeating the same thing, but is very poorly understood. And so actually, I worked very closely with a group when I was in grad school that was working on trying to understand these better. And there were a ton of really smart people in that lab, a ton of people I really respect, but despite years of work, there's still a lot to learn. And so this image right here is actually from one of their studies that they did. Was they found a patient. This is a particularly severe aneurysm here. I mean, the one I showed you before was extremely severe, but and they were looking at is kind of they ran a simulation and they were measuring kind of the ratio of the shear stress versus the pressure on the aneurysm. And what they found was that because there's such a very wide kind of opening here, this ratio is very, very small. And so this entire aneurysm here kind of is exposed to very low wall shear stress. And so they're trying to link that with kind of outcomes, but again, compelling results, but they don't have data on a ton of patients, and so it's really hard to say if it's going to apply to everyone with these things. Right? So some factors that may lead to rupture and growth is age. And so, if as you age, a lot of the natural elastin and a lot of the natural kind of strengthening materials in the vessel wall tend to just degrade over time. So that may lead to rupture. Okay. And again, wall shear stress. And so there's a lot of kind of research into linking wall shear stress with a lot of diseases. Okay. Any questions on aneurysms here? Okay. All right, so that's enough with diseases. So there are more diseases out there. There's certainly many more diseases. One disease in particular, I don't have slides for it, but I know that quite a few of you have it for your projects. It's called the coarctation. And so let me spell that for you. So coarctation is C-O-A-R-T-C-T, coarctation. Coarctation. So coarctation is actually kind of the opposite of an aneurysm, where an aneurysm is kind of like an expansion of a blood vessel. A coarctation is kind of like a narrowing. So you kind of have a very local kind of rapid narrowing. It almost looks like someone took like their fingers and kind of pitched a blood vessel like this. And so normally a healthy blood vessel may look straight like this, but with the coarctation, it almost looks like an hourglass. So it looks like, oops. Looks like this. So it looks almost like cartoonish, and so it almost looks like a cartoon person's blood vessel, but it's a real disease and it's a real issue because it definitely restricts blood flow. So quite a few of you, I think, have a coarctation in your models, and so if you're looking at your PDF, if you're looking at your images and you see kind of a very rapid kind of decrease in the cross-sectional area, you likely have a coarctation. I think some of the animal models have that too. So they were, a lot of cardiovascular research is done in animals, and so they either find animals with the disease or they, sometimes unethically they try to artificially put the disease in the animals, and so they'll and they'll study it from there. So I don't have slides on it, but I did want to mention it just because I know quite a few of you have that for your projects. Okay. All right. So now that we're done talking about diseases, let's talk about medical devices. And so this is kind of part 2 from your first homework assignment. So if you remember from your first homework, I had you guys do a bit of research into a medical device of your interest. Okay. So for most of you, you'll probably kind of know part of what I'm going to say now. But this is kind of your chance to learn more about all the other medical devices that are commonly used, okay? And so again, a medical device is just any kind of man-made, device or invention that's used to treat or manage cardiovascular disease, okay? And this is usually what's done when kind of like drugs or medicine is not effective, right? So a lot of these devices, even though we call them medical devices, really these were designed by engineers and kind of a lot of what you already kind of understand about just mechanics and fluid mechanics and structures and fatigue. You should understand a lot about how a lot of these devices work, because some of these are nothing more than just a valve. Some of these are nothing more than just like a pipe that goes in, right? So a lot of these, one of the surgeons I used to work with always used to joke that he said, a plumber can probably understand some of these devices better than I can, just because that's kind of where the technology is based in. So what we're going to do is we're just going to do a survey of the different medical devices, how they work, and kind of what applications that they're useful. Okay. So first, before we jump into the different medical devices, let's talk about different types, right? So there are kind of two broad categories of devices out there. So there are active devices, and so active devices are devices that require some sort of energy source. So either a battery to operate, or I know some devices nowadays that use kind of some external magnetic coil charging, which is kind of crazy. So usually for a lot of active devices, these are not meant to be used long term, with some exceptions. Of course, pacemakers are in there kind of long term for people, but a lot of active devices, just because of the power requirements, are mostly meant to be kind of a temporary thing. So we're going to talk about this particular device called an LVAD, which is a very fascinating device. But probably what you're going to see most commonly for most people are passive medical devices. So these are devices that don't require any energy, and most of the time they're just kind of part of your cardiovascular system. Okay. So first, let's go over kind of the most basic cardiovascular device called a graft. Okay. And so a graft is nothing more than just an additional blood vessel that's used to either repair, replace, or bypass a diseased section of vessel in a person, right? That's a very fancy way to just say it's just a piece of tubing. And so you take kind of like a Teflon tubing. It's not made of Teflon, but same idea, that you would use to kind of connect two things, and that's essentially what a vascular graft is. Right? So mechanically, these are very simple, and so because they're nothing more than just a pipe. What's challenging about vascular grafts is not really the mechanical side of it, but more so the biological side of it. Right? So what's challenging is that if you put an artificial blood vessel inside your body will likely identify it as something foreign, or something that doesn't belong there. And so your body will either start to attack it, or they'll start to close it off from the rest of your body. And so what can happen a lot is that if you have like a pipe like this, and so let's say it's connecting between two different parts in your body, right? So you have this section of blood vessel in your body. And so if you have blood flowing through it, right, what's going to happen is that as the blood flows through it, your blood's going to be like, wait a minute, that was weird. That wasn't supposed to be there. And so what your body will then do is it'll start to send cells in. So it'll activate your immune system. And so it'll start sending white blood cells. It'll start sending, the platelets in there to kind of repair something. They'll try to see what's up. And actually what tends to happen is that these grafts tend to actually kind of plug up on their own. Right? So one example of this, and this is a subject that I actually worked on a lot when I was in grad school, are for patients with heart bypasses, right? So for patients that require, they call it coronary bypass surgery, they often require, oftentimes 2 or 3 different types of grafts, in their body at one time. For a very particular type of graft, what tends to happen is that over the years, over 5, 6, 7, 8, 9, 10 years, that graft tends to kind of plug up on its own, just because the body senses it as foreign and kind of sends blood cells there to kind of fight it and try to block it off. And when these grafts are meant to basically provide blood to very key critical areas of your body, if these grafts get plugged up, then it kind of defeats the purpose. And so these patients either end up well, in the worst cases, they end up, dying from it, but then, they also may have to come back and get surgery again. And, getting open heart surgery to get these grafts is already a very risky kind of harrowing experience. And so to have to go through that twice is, not very good. So one of the big projects that I worked on in grad school was doing simulations on these to see if there's any correlation between the fluid mechanics and these particular grafts and kind of the risk of failure. That's what we call them. So if a graft plugged up, we called it a failed graft. And so that was kind of one thing that we worked on. Right? What's interesting about those grafts is that those grafts were actually harvested from inside the person's body, and so the most ideal type of graft that you can get is kind of a redundant blood vessel inside the person's body. And so if you can get a redundant blood vessel, you can take it out from one section, put it in another. That usually has the highest chance of success. And so the body will then recognize it as its own and then not try to attack it and just let the blood flow through it. But what we were finding out is that, a lot of the redundant blood vessels are actually in your leg. And so what doctors were doing was they were taking kind of a blood vessel from your leg, sticking it near your heart, and then using that as a graft to, reroute blood around your heart. The challenge with that is that, around your heart, blood pressures and blood velocities are extremely high. And so if you take a blood vessel from your leg, the blood flow in your leg is actually quite slow and quite steady. And so what can happen sometimes is you have very maladaptation of the blood vessels when you kind of put it in a very different environment. And so that's kind of the link that we're starting to see with the simulations, that these are much higher velocities, much higher pressures than they're used to. That's the most ideal case, but sometimes you don't have enough redundant blood vessels in your body because your cardiovascular system wasn't really designed with a lot of redundancy in mind, and so sometimes you have to use artificial grafts. And so these are kind of grafts that are made in a lab called synthetic grafts. So they've come a long way, but there's definitely still a lot of work to be done. And so usually these are kind of like a last resort type of thing, to resort to a synthetic graft. Okay. And synthetic grafts are known to have kind of a higher rate of failure. All right, any questions on grafts here? Okay. Okay. Next, let's talk about a stent. And so a stent is an expandable tube that is inserted into an artery and then kind of expanded to kind of push away either some disease or some plaque, most of the times plaque, right? Or sometimes it could be inserted to support, a blood vessel that may be very weak and needs just some structural support to kind of maintain itself. Okay? So stents are very common to treat what are called single vessel stenosis. And so whenever you have kind of plaque disease in just one vessel, when it's kind of very localized to that one vessel, doctors will go in and treat it with a stent, most likely. Just because the procedure of putting a stent in is actually very non-invasive compared to some of the other methods. And so, let's say for a graft, right? And so to insert a graft, it almost always requires either open heart surgery or open brain surgery. So it's a very extreme thing with like weeks and weeks and weeks of recovery. For a stent, you don't have to open a person up to insert a stent. And so you can basically, find an access point, usually through the groin, and then kind of snake kind of this device, a catheter, up to where the blockage is, and then deploy the stent, and then just retract the catheter through the groin. So you just kind of have one incision on your body, sometimes more than one, but a small incision is definitely much easier to recover from than a huge, they open up your chest, they literally cut your ribs and open it up and then, operate on your heart. So, if a doctor can fix you with a stent, they're mostly going to do that. So stents are definitely a lot more common than grafting or open heart surgeries. Okay. Okay. So like I mentioned, these stents are deployed using another device called a catheter. And so a catheter is nothing more than just a guide wire that comes along your blood vessels, right? And it's called a minimally invasive procedure. And so these are, again, ideal if you can do it. Right? And the thing with stents is that oftentimes they're coated with some kind of chemical to make sure that there's no adverse effects from the human body. Right? So just like grafts, the body can recognize that if a stent is foreign to the body. And so oftentimes these are coated with some kind of material or some kind of chemical to kind of help it kind of, help tell the body that it's okay to suppress some kind of disease immune response. Okay, so let's see if this works. Good. All right, so I have a video here, and so it's just a very kind of short cartoon to kind of show you what a stent looks like, right? And so before this video starts, you can see all this yellow here. So all this yellow here is kind of plaque that's kind of deposited on the vessel walls. And so, this person has some pretty severe disease, or well, this cartoon person has some pretty severe disease, and they're going to insert the stent to kind of fix it up. Okay, so you see that there's a disease. They insert the stent. They literally kind of inflate the balloon and kind of smush the disease back. They leave the stent there, and then it becomes a part of the blood vessel. You can see it one more time. I think this video is like 14 years old, so I'm glad that they didn't take it down. Right? Yeah, so it looks pretty straightforward, but there's of course there's a lot of science that goes into it, making sure that the stent is made of the right material, making sure it has the right strength, making sure that it expands okay, making sure that it sticks there, right? There's a lot of really interesting science that goes into a stent. Okay. In particular, let's talk about some complications. And so, even though a stent is a lot less invasive than doing a bypass surgery, you're still sticking a foreign object within your body, right? And so there's risks that are involved with the body rejecting it. And so the first complication that can occur is restenosis. And so in restenosis, what can happen is that after you expand the balloon, right, and the coils kind of like expand out, there's a chance for there to be kind of elastic recoil from the vessel walls to kind of almost like crush the stent back into its place. And so it kind of narrows the artery kind of even more than it was before. So this can happen if honestly, if your doctor is a kind of a noob. So if your doctor kind of knows what he's doing, then this usually doesn't happen, because there's a proper placement, a proper alignment for the stent to kind of minimize this risk, right? But in the early days when stents were first being developed, this was quite a common occurrence before we figured out how to do it. Okay. The other risk that can happen with deploying a stent is injury to the vessel wall. And so when you kind of take a stent and you kind of rapidly expand it, you're literally kind of smushing and kind of pushing against the vessel wall, and you're applying a lot of force, a lot of pressure that the vessel wall may not be used to. And so what that can do is that can actually, damage and injure a lot of the cells within the vessel wall itself, and this could cause a lot of adverse responses. Right? And so, this type of disease, when the vessel wall is injured and it starts to have kind of an immune response, this is called neointimal hyperplasia, or NH. Okay. All right, but these two, for the most part, if your doctor kind of knows what he's doing, then their risk is minimized. And so there's a particular technique to deploy the stent to kind of minimize these risks as much as possible. Oops. Okay. All right. So the last thing I'll say about stents are the different types of stents that are out there. And so, because stents are used very commonly, there are quite a few medical device companies that are devoted to developing them. And so all different types of patterns, all different types of materials, all different types of drugs have been developed to with the stents, right? So honestly, there's a lot of variety out there, and kind of too much for us to kind of cover within this class. And it's a little bit kind of outside the scope of this class as well. But I will give you kind of two kind of broad categories out there. Right? So the first type of stent, these are mostly being phased out nowadays, are called bare metal stents. And so these are wire mesh stents that kind of look like this, and they're comprised of a specific alloy of steel, so 316L steel. Right? So these stents have pretty good material properties and pretty good corrosion resistance because they're made of steel, and they've actually been found to have pretty good biocompatibility as well. So, these have good compatibility with the body. And so the main concern with using these stents is neointimal hyperplasia, NH. Okay? All right, so the other type of stent that we have is called a drug-eluting stent, or DES. So this is the most common type of stent nowadays. And so these are stents Also made of a particular alloy of steel, although it's hard to get information about what people use because these are all proprietary now. The only reason we know this is because the patent has kind of worn off on this one. But a lot of companies have their own kind of alloy of steel, so it's a little bit hard to get information about what specific metal that they use. And I think a lot of companies now are using composite materials as well. It's just they don't talk about kind of what material they actually use. That would be a trade secret. But the main difference here is that they coat their stents with some kind of drug. So they literally dip it in some kind of medicine with kind of bioinhibitors. That's what they usually do to kind of inhibit the inflammatory and the immune response in that area. So and so that's kind of the more common ones nowadays. A very new type of area, and there might have been a lot of progress on it since I've kind of last been really in the field, is this idea of a fully resorbable stent, right? And so kind of the downside to these stents right here is that once you deploy them, they're kind of there forever, and your body may not need them forever. So it may just be needed in the short term to kind of open up a blood vessel. But if it's not needed anymore, you kind of have this piece of metal stuck in your body, and so. Which, for the most part isn't that big a deal. But if you ever need to get an MRI or if you're walking through metal detectors, they're going to pick these things up and which is not good. So, and so research is being done to, develop stents that are made of some kind of biological or biodegradable material that, once they're done, or once they've kind of served their purpose, they kind of either fully absorb into the body or they kind of disintegrate in a way that's kind of safe for your body so that you no longer have this piece of metal. Right. I think the challenge that people have is that, creating something that can be degraded, but still have enough strength to kind of do what it needs to do in the short term. So I think there was some interesting research at the time. I don't know if there's any companies that are really dealing with this yet. I think it's still kind of mostly in the labs right now. But we may see this over the next few years. If not, some people may be trying for it. Okay. Any questions on stents? Yes.
I have a statement. My friend Chirag excuse me, is actually doing his thesis on a biodegradable ureteral stent.
Yeah.
So yeah, there's research going on.
Awesome. That's good. Yeah, I made these slides about 3 years ago, so I imagine there's been a lot of research done since then. But yeah, there's a lot of interest in it just because there's so many benefits to having a stent that just automatically just resorbs itself.
He's 3D printing it too.
Awesome. Yeah, that makes a lot of sense. Use 3D printing to do that. Yeah. All right. Any other questions on stents?
When would you have a condition where you would need a stent and not? Like, isn't plaque permanent in like a blood vessel? So I don't see you ever not needing a stent if you needed one. How does that work?
Yeah, so kind of the big difference that doctors contend with is like, do I put a stent or do I do just full open heart surgery? And so honestly, it's hard to give you a straight answer because every surgeon kind of has a different opinion on it. And it's one of those things that's kind of academically up for debate. But generally, the trend that I see is that if you only have disease in just one vessel, then they would use a stent to fix it, just because it's just one. But if you have multi-vessel disease, or if the disease is, they call it diffuse, and so it's kind of over a long stretch, and it's kind of too long for a stent, then that's when they'll use bypass surgery for that. But then you also have some surgeons that are very bypass happy. It's like, yeah, just bypass everything. I get paid to do bypass surgery, so we'll do bypass surgery. So, you have some little shady conflicts of interest in that case. But for the most part, if it's small and it's single vessel, to do a stent. If it's too complicated, then they'll do bypass. Yeah. Okay. Yeah, the funny thing about bypass is that once you bypass a vessel, that other vessel that you bypass is considered dead, basically. So that it can continue plugging up, but you've kind of rerouted blood around it. So it's kind of not an issue. Yeah. Okay, so let's talk heart valves. And so heart valves are very interesting. Very exciting in this portion of the world too, because we have a company that's down in Irvine that specializes in these, and so probably most of you have heard of Edwards and Life Science, and so the division that actually is here in Irvine, they specialize in heart valves, and so if you ever get a chance to visit their campus, they actually have kind of like a mini museum of heart valves, so you can see kind of the development of valves that they've created over the years, and it's very fascinating. So Like the name implies, a heart valve is an artificial valve, and most of the time, or the most valves that kind of get the most attention are the four that are in your body or in your heart, excuse me. And they all have a very slightly different structure, but they all kind of have some similarities. And they all have kind of this leaflet design. So what that means is that these valves kind of open up and they kind of have these leaflets that kind of come up and allow flow like that. Okay. And so ideally, these valves, they don't really behave all that differently from the valves that you expect in your faucet. And so they should allow unimpeded forward flow when they're open, and when they're closed, they should completely block off the flow. Okay. But even though for the most part these work pretty well for most people, they are still made of living tissue, so they can get disease like any other part of your cardiovascular system, which can lead to a lot of adverse effects. Okay? So the two most common types of valve disease that are out there is a stenotic valve. And so in a stenotic valve, the leaflets become very stiff. And when they stiff, they can't really open properly. They can't really close properly. And so that kind of impedes the forward flow of the blood and kind of puts a lot of extra strain on the heart. So your heart has to work harder to kind of push blood through kind of a smaller opening. Okay. The other type of common valve disease is called the regurgitant valve. And so these are valves that fail to close properly. And so when they should be blocking flow, they kind of let flow kind of leak through itself and kind of go backwards. And so this can cause a lot of issues, because not only does it put extra strain on your heart, but it can also cause mixing of blood. And so you have blood that's kind of mixing with other types of blood, maybe oxygenated blood and deoxygenated blood mixing together. And that kind of lowers the efficiency of your cardiovascular system, which can lead to a lot of other issues in the long term as well. Okay. Okay, so to fix this, whenever you do have a diseased valve, is to implement an artificial valve, right? And so the thing with valves is that they're very difficult to repair themselves, especially with kind of some serious disease. And so, an artificial valve is kind of the way to go. Okay. All right. Valves are very difficult to design. And if you talk to anyone at Edwards Lifescience, they will tell you pretty much the same thing. So valves have to have kind of this, a valve in your heart, I should say, have to be extremely durable. And so these are valves that are opening and closing, literally every second of your life, right? And they have to last for your entire life. Okay? So on average per year, this valve must open and close about 40 million times. And so you multiply that for, however long a person has a valve in their heart, that's a very long time. Okay? They must be non-thrombogenic. And so what that means is that they don't encourage the blood to clot. Okay? And they must be effective enough or have a large enough opening to let flow through and close completely. So these are, this is you can almost consider this to be kind of the set of design requirements for a valve. Right? And satisfying all of these conditions at once is very difficult, because some of these conditions kind of impede with each other, right? And so having a valve that has a very large opening, what that basically implies is that your leaflet should be very large, kind of open up like this, but that makes it hard to be durable, right? Having a valve that's non-thrombogenic means that you're not going to have any kind of hard surfaces or sharp corners. But that's hard to do if you want a valve that closes completely as well. So this set of requirements is very complex. It's a very hard it's a very clearly defined set of requirements, which is kind of unusual for the cardiovascular system, but it's very hard to achieve in general. And so in terms of the valves that are currently on the market, there are kind of two main categories. There are mechanical valves. And so these mechanical valves, they look, more or less similar to the valves that you would expect to see in a plumbing system. And so they kind of look closer to this. And there are biological valves that look more kind of like a biological kind of thing. And these may also be made of animal tissue or synthetic tissue. Okay. So let's talk about the procedure to actually implement one of these replacement valves. And so these are called valve replacement surgery. Okay. This is another type of surgery that is very delicate and also very difficult to do. And so, if you take anything away from this lecture the last 2 days, that all these procedures, they're all extremely cool. It's really cool to think about, but you also want none of these happening to you because it's, you know, it's very dangerous and very risky to do. And it's going to take weeks of recovery, right? Valve replacement surgery is particularly crazy. And so, you know, in order to replace a valve, that means you have to take the old valve out. And it's not like there are kind of, you know, latches inside your body to take these valves. These valves are not really meant to take out the person. So you have to go in with a very precise knife, a very precise, you know, hand, and kind of literally cut the valve out of its, you know, of its place, right? Kind of do it in a way that doesn't, you know, completely screw over your cardiovascular system, and then put a new valve in there, suture it in place, secure enough so that it's going to stay there forever, and not have any leaks. And then, you know, send the patient on his way. So it's a very delicate, very kind of dangerous procedure. Right? So it used to be that this procedure was very much like kind of like a bypass surgery where you have to open the patient up, open heart surgery, saw through their ribs, and kind of do it that way. But there's been a lot of research in doing this in kind of a non-invasive way. And so a lot of hospitals are actually adopting this approach, something called the transaortic valve replacement, or TAVR, TAVR, right? So the transaortic valve replacement aims to use a catheter. So same kind of device that deploys a stent. And then they use that with a very specialized head here to kind of take the old valve out and put the new valve in, all while doing it with just a single incision in your bone. And so they're trying to do it very minimally invasively. And so this was, you know, when I was back in grad school, this was kind of just becoming a thing. And so I think it's probably more common nowadays. Okay. All right, so let's talk about some of the design considerations for a heart valve. And so these are kind of what a lot of the engineers at Edwards Lifesciences are contending with every day. Okay. All right, and so ideally what we said is that for a valve, you know, there should be no flow obstruction when they're open. So when they're open, it should just let flow freely come out, right? But some flow obstruction is going to be inevitable, and even for your natural valves, this is the case because of the leaflet kind of design. So, you know, because there kind of has to be either a plate or some kind of, you know, gate that opens up, you know, that gate has to come closed again at some point. And so that gate, just by being there, is going to obstruct the flow to some degree. Okay. Similarly, you know, even though it would be ideal for the artificial valves to prevent all regurgitation, some regurgitation is inevitable because as these kind of leaflets or as these kind of plates kind of swing open and swing close, it's going to take some blood with it when it swings close. And so some regurgitation as it's closing is inevitable. And so, but that's okay, right? The thing that's really difficult to emulate is that in your body, you know, your natural valves are very flexible. And so they open up and they're very kind of like almost kind of flowing like this. And so that flexibility kind of allows it to prevent a lot of the, you know, it allows it to open up very cleanly and also close very cleanly as well. And that's very hard to kind of replicate with an artificial valve, especially with mechanical valves, right? Right. And so to analyze a valve or to evaluate a valve performance, it's very common actually to use CFD, so computational fluid dynamics. And so one of my close colleagues actually, you know, worked very closely on these valves and ran a lot of simulations to kind of assess their performance. Another thing that valves must consider is energy efficiency. And so they should open and close, you know, without too much effort from your heart. Because if it takes a lot of effort to open up these valves and close them, you know, that's going to put extra pressure on your heart, which can lead to heart failure. Okay. Right. So let's talk about some complications that arise with heart valves. So the primary health concern for artificial valves is clotting, right? And so as the blood passes through a valve, you know, there are a lot of kind of turbulent flow structures that kind of pass through like this, right? And so you can see the valve opens and then it creates a lot of these vortices and kind of twisting flow. Right? And whenever you have kind of a lot of very disturbed flow patterns in the cardiovascular system, there's always going to be concern for clotting or thrombosis or things like that. Okay. And so if you have an artificial valve in you, you know, at least for the short term, you know, at least for the first few months that you have the valve, it's very common for the doctor to prescribe blood thinners for you. Okay. And so blood thinner is basically a drug that you can take to kind of prevent the clotting response. Right. And another thing that you can undergo is anticoagulation therapy, which is, some kind of it's basically a procedure that's done to kind of inject something with you to kind of do the same thing, to kind of prevent your blood from clotting, right? So that's fine. But blood thinners also come with their own risk because, as we talked about before, clotting is a very important response for your body to do. That's how your body kind of repairs injury. So I always remember this. So whenever I used to work with a surgeon, and he was like, when I put you on blood thinners, I always tell my patients, don't go out scraping your knee because you're going to bleed to death if you scrape your knee, right? Because usually if you scrape your knee, you get a paper cut, right? Usually, you kind of cover it up for a bit, you apply some pressure, and the blood naturally clots and closes the wound, right? That's how it works. But if you're on blood thinners, you get a paper cut or you scrape your knee, there's nothing that's going to actually clot the blood. So you can actually bleed out just from a paper cut if you just leave it on the table for whatever weird reason, right? So there's a lot of risk with that as well. Okay. Okay. So one thing that used to be a concern with valves was kind of structural integrity and durability. We've mostly figured that out at this point. We've done a lot of really good materials engineering and found good materials and good designs that are strong and durable. Okay. So a lot of the research with valves now is actually with the implementation. So with the surgery, we talked about TAVR and using CFD to kind of further improve these valves. Okay, any questions on heart valves? Okay, so those are the main kind of fluid mechanics devices that are out there. Let's talk about some more active devices. And so one active device, you've probably heard this before, is a pacemaker. Okay. So pacemaker honestly doesn't have too much to do with this class because it's more electromechanical more than anything. It doesn't really have to do with the fluid mechanics, but it is very common, so I thought I would mention it. Okay. And so a pacemaker, the main role of a pacemaker is to make sure your heart kind of beats at a steady rhythm. Okay. So what can happen to some people is that their heart can kind of start beating out of rhythm, right? Because we're not going to talk about it much in this class, but there's a very specific way that your heart beats. So, and the way that your heart beats, or the way that your heart muscles get the signal, is that your brain is constantly sending a signal, an electrical signal through your nervous system, and it goes to your heart, and it triggers in a very specific sequence to make sure that your blood pumps, right? And so that's why you use here a and so that's your heart kind of beating in rhythm. But if there's any kind of issue with your nervous system, or if there's any kind of issue with the electric circuitry inside your heart, then your heart may have trouble getting those signals and kind of beating with an appropriate rhythm. And so what a pacemaker does is it kind of aids in that electrical signal by providing the needed electrical impulses. Okay. Okay. So the way the pacemaker works, and so this is kind of a cartoon of it, but there are these electric leads. They literally look like little wires, and they're attached to kind of key areas of your heart, right? And then those wires are attached to a device here, and this device is nothing more than just like a pulse generator, basically. So they generate electric pulses and they send them through the wires, right? And they're carefully calibrated to kind of recreate kind of the electrical signals from the nervous system to provide the heart with the appropriate signals. Okay. So pacemakers are very common, mostly just because it's very easy to diagnose someone with an irregular heartbeat. Okay. So relative to a lot of these diseases like aneurysms and other stuff where you actually need to do a scan, to tell if someone has an irregular heartbeat, you just need a stethoscope, and that's kind of what your doctor is kind of searching for when they put that stethoscope all over your body. So pacemakers are more common just because it's easier to detect. Okay? So older versions of the pacemakers would actually apply the electrical circuit directly to the skin, so they're actually on top of your chest, well, I say it's funny. It's not actually funny, but sometimes these electrical signals need to be strong enough because these signals need to penetrate through the skin in that case. But sometimes these signals would be so strong that they would actually cause electrical burns on the person's skin. So we figured out a better way to do this. Now these are actually implanted within the person, and there's very kind of efficient ways to do this so that doesn't have to happen. So it reduces the power needs and makes it a lot safer for the person. Okay. All right. Any questions on pacemakers?
when your heart is like beating like irregularly, you still kind of like you're still receiving like electrical signals like from your brain, right?
Yeah.
So how does your body know like which electrical signal to like prioritize over the pacemaker and like your brain?
Yeah.
Assuming you're still receiving like signals from your brain, even though you have like the pacemaker in it.
Yeah, so it's a lot of the signal processing, and so it's making sure that the frequency is correct. And I think what the doctors will do is that they'll kind of look at the structure of your heart, because a lot of times an irregular heartbeat is caused by your heart just may be kind of a weird shape, and the signal doesn't travel as efficiently around the heart as it needs to. And so what they'll do is they'll kind of add the electrical signals in there to kind of boost kind of the signal that comes from your brain and making sure it's all timed correctly. So a lot of times it's not a complete overriding, it's just kind of aiding that signal and getting to where it needs to be. Okay, next let's talk about a ventricular assist device. So this device is actually pretty crazy. And so, this device is basically a blood pump. And so this is a pump that you can add to your heart that's used to kind of assist a failing heart, right? And so usually when a person undergoes heart failure, that's when the heart is not usually either not strong enough, or or the muscles just start to fatigue, and it can't provide all the power that needs to drive the blood through your body. Okay. So usually these patients that have a failing heart, they have to get a heart replacement, right? So it's their heart's just not working. But the thing is, with heart replacement surgery, it's a very hard thing, because not only is it a very extreme surgery, but you need to find someone that can donate their heart, a dead person to donate their heart, that's compatible with you. And sometimes that can be very difficult to find, just because not every dead person is willing to donate their body to science, right? And so you may be just honestly, you might just be waiting for months or years before you find someone with a compatible heart to you, right? And so in the short term, we can mechanically kind of boost your heart, to give you the power that you need to kind of pump the blood through your body. So that's essentially what an LVAD is. So an LVAD is just basically a pump that's implanted to kind of, mechanically kind of pump the blood to your body that your heart may no longer be able to do. Okay. Okay, but it's not a long-term device. And so, it's actually a device that's very invasive to your body. And so, to provide any kind of pumping, it's a lot of these pumps are rotary pumps. And so they involve kind of a spinning rotor that kind of pushes the blood through. And so that's a very violent process. And so what's very common in these devices is blood clotting. And so, these patients are certainly on blood thinners. Otherwise, the blood's going to clot within the pump itself, right? But blood thinners also is not something that you can maintain for a long period of time, because, like we mentioned, if you're on blood thinners, if you have an external wound, that won't heal. But you may get internal wounds as well. So if you get internal bleeding, like a bruise, if you're on a blood thinner, you're kind of you're kind of in trouble. And so having someone be on blood thinners is not a long-term sustainable solution. So the LVAD is only meant to be there for kind of a short term until someone can get like a real kind of working part. Okay. But even implementing the LVAD is a risky procedure as well, because it involves an open heart surgery. Most of the time, I think nowadays a lot of these have an external power source, and so there's like a battery that you wear externally. This is kind of a cartoon. No one's actually walking around with batteries kind of around their jock straps like this. Usually, it's some kind of unit that's attached to their back. But it's having that much power attached to the body is also kind of a risk as well. Not a long-term solution, but it saved a lot of lives from people that have been waiting for heart replacement surgery. Okay. All right, any questions on LVADs? I saw a really crazy one when I was in grad school. I went to someone's talk that the danger of an LVAD is that you have so many mechanical parts, and they're so foreign in the body. So this person, he was crazy, by the way. He was basically booed off the stage, but he had a very interesting idea where, I don't know if you guys have seen the movie Inception, but in the movie Inception, Leonardo DiCaprio has this totem that's like kind of a top. And so we said, what if we put that top magnetically levitated within your blood vessel and then spin it using a magnetic field, and then have that provide the power and the thing, to push your blood through. It's non-invasive, so you don't have this huge kind of device within your body. You know, there's minimal risk for blood clotting, and it's just really cool. But and so the idea from it is like based off like a very old I almost said Leonardo DiCaprio, Leonardo da Vinci design for like kind of a pump that kind of spins like a top. Uh, his issue was that, you know, he was a doctor and he was not an engineer, and he didn't realize that there's a reason no one makes pumps like that nowadays because they don't really work that well. So yeah, he was kind of booed off the stage, but it was interesting, interesting to work. His proposal was to kind of walk around with a vest that kind of provides a constant magnetic field throughout your body, so you kind of have an MRI going through your body at all times. And so, yeah, crazy, but entertaining. My advisor made me wake up at 6 o'clock in the morning to see that talk. So I think everyone was also kind of grumpy. So I think that's why they booed him off the stage too. Okay, so let's talk complications. So the VADs have a lot of complications. You know, they're not a long-term solution, right? So like we talked about blood clotting, and so there's a huge risk for that. Okay. Because, you know, devices like this that have an external source, you know, they're not really worn like this, you know. They're usually kind of implanted. But anytime you have kind of wires or stuff that's kind of penetrating the skin, you know, that comes with an infection risk, that comes with a bleed risk, right? So yeah, there's a lot of risk with LVADs, and so it's yeah, not something you want happening to you, although the device itself is very. Okay, so last thing I want to talk about today, I think we're going to end a bit early, is regulation. Okay. So medical devices are what's known in the government as safety critical devices. So, so just like airplanes and you know, just like automobiles, you know, the failure of the device can lead to significant harm or death of a person, right? And so because of that, their development and their sale and their research is very heavily regulated by the government, right? And so in particular, the government agency that primarily works on this is the Food and Drug Administration, the FDA. Right? And so if you want to develop a medical device and sell it to hospitals or sell it to the general public, you have to go through tons of red tape. There's a lot of approval procedures, a lot of tests that you have to run. And so it can be frustrating, but it's important. You know, we want to make sure that whatever device that we're selling to the general public is actually going to be safe for them, you know, in general, right? And so there's a lot of processes that you have to do. And so, you know, because of that, you know, it makes it actually very difficult for kind of smaller companies to kind of break into this market, because in order to kind of comply with a lot of these regulations, a lot of these procedures, you need a very kind of a powerful kind of legal department. You need a very large compliance department. So, you know, it's kind of raised the barrier of entry for a lot of kind of smaller companies. And so most of the players that you see in kind of the biotech realm and the medical device realm are these gigantic companies, you know, with billions and billions of dollars of market cap, just because you need all that, you need all those resources just to put even just one product to market. So yeah, it's very hard, but you know, I can kind of understand why in this case. But just like all things, you know, it's impossible to eliminate all the risks that are associated with medical devices, but you know, we can try to minimize these as much as possible. And that's what the FDA aims to do. And that's kind of their general approach. Okay, any questions on that? Yeah.
Do you happen to know what safety factor the medicinal devices usually operate at?
Yeah, so it's I would say that it's mechanical failure is usually not the concern for a lot of these medical devices. So they usually don't talk in terms of like safety factor. They talk more in terms of like risk factor, in terms of like the percentage of these devices that will either cause like a clot or that these will cause some kind of critical failure for the patient. And so, you know, that's the main thing. You want to get that number down to like less than like, you know, 0.1%.
So they operate more like in risk matrices?
Exactly. Exactly. Yeah. Yeah, very, very rare for these to have any kind of mechanical failure. I think maybe in the very early days, graphs were kind of subject to that, like they would kind of literally rip apart. But I think nowadays that's not really as much concern. Yeah. All right, so that's all I got planned for today. I didn't bring the next set of notes, and so we finished a little bit earlier than I thought, so that's fine. So on Thursday, when we come back, we're going to start a new set of lecture notes on 1D equations. It's very math heavy, so definitely bring your pencil and paper. So yeah, so thank you guys for coming today. Hope you guys enjoy the rest of your day. Hope you guys enjoy the new sunlight that comes with daylight savings times. And I will see you guys on Thursday.
I have a question about the model.
Yeah.
I was kind of, because I chose the congenital heart disease. Yeah. I was kind of like wondering, like, what about this model is a disease?
Yeah. So actually, this is post-surgery.
So it's like mixed.
Exactly. So these patients, most of them are born with heart. So remember we talked about we have the right ventricle, left ventricle. These patients are only born with one. Usually it's the left ventricle.
Something like a bypass.
Exactly. So actually, so these two vessels right here, these are normally connected to the heart. So this is your superior vena cava and inferior vena. So normally these pass through the heart and your right ventricle and you come to your left. And so these vessels are kind of go to the right and kind of branch out. Those are your pulmonary vessels. So they go to your lungs. So normally there's a heart that kind of is in there that pumps the blood here. But because that right ventricle is usually gone. And what doctors have done is they kind of created one unified circuit to directly connect these two, and then that left ventricle kind of pumps the blood through the rest of the body. So this is post-surgery. So this is after the connected those ones.
Okay, that makes sense. And also a question about like the 1D model.
Yeah.
Is that more of a kind of, because like I'm taking CFD.
Yeah.
So I was wondering if that's like also like discretizing, like
It is, yeah.
Discretizing methods.
Yeah, yeah. So yeah. So actually, so the 1D, even though they're 1D equations, they are actually they're still partial differential equations. So we have both time and space, and so they're very difficult to solve. But most of the time, we solve them numerically using code. Okay. So we'll go over that a little bit. So I do have a sample code. I'm not going to expect you guys to develop it. It's crazy, but
yeah, we just finished doing that for CFD.
oh, nice.
We actually had to like whole method. We had to like hand discretize like the ODEs.
Yeah.
Like with the PDs with stitch like different methods.
Yeah.
And
That's crazy.
yeah, we had to hand discretize and then do the code. Yeah, that was like
I saw the syllabus that he's having you do for CFD. It go crazy.
Well, that part's like that part's done. So like we got past the hard part. And
Okay.
Just like a little bit more calm. Yeah. So when I heard like 1D modeling, I was like, oh, I have to go through all of that.
We'll go through we'll go through the derivation in class, but I'm not going to have you code it.
Okay, for sure.
We're only going to spend like a week and a half. Yeah, not too much time because we have to get to actual CFD at some.
Oh, okay, for sure. All right. Thank you.
Yeah,
appreciate it.